طبعا بحضراتكم جميعا. طبعا بيشرفنا الاستاذ الدكتور عصام بليغ ومجموعه كبيره جدا من الزملاء الافاضل. طبعا يعني I'm going to present a very important topic, hypertrophic cardiomyopathy, practical considerations. Hypertrophic cardiomyopathy, we know that it is a life-threatening disease, fascinating disease, over many years, a heterogeneous disease at all levels, at the level of genotypes, phenotypes, clinical expressions, even variations in response to treatment. And we have to know in details, starting from the definition up to management strategy, especially for high-risk patients. So we can say that hypertrophic cardiomyopathy is defined by the presence of increased LV wall thickness, which is not explained by other conditions like hypertension, aortic stenosis. So a wall thickness more than 1.5 centimeter in one or more of the myocardial segments, or more than 1.3 centimeter in a first degree relative of someone who have cardiomyopathy, hypertrophic cardiomyopathy, which can be measured by any imaging technique like echo or CMR, as we will see later. So overall, the disease affects around 0.2% of adults. Hypertrophic cardiomyopathy can be caused by many genetic and non-genetic disorders. Up to 60% of patients with hypertrophic cardiomyopathy, the disease is an autosomal dominant caused by mutations in cardiac sarcomere protein genes. 5 to 10% of adult cases are caused by other genetic disorders, like inherited metabolic or neuromuscular disease, as we will see in this slide, that beta-myosin heavy chain gene mutation is the most common type genetic mutations responsible for the disease. Others like myosin binding protein C, troponin I and troponin T, tropomyosin alpha 1 chain, and the myosin light chain 3. All these mutations represent the main genetic forms of hypertrophic cardiomyopathy, a disease which is characterized by the presence of myofibrillar disarray. Other storage diseases which are should be diagnosed as a cause for the same LVH, like Anderson-Fabry disease, Danon disease, Pommes disease, and neuromuscular like Friedreich's ataxia, and malformation syndrome like Danon syndrome, which is characterized by hypertrophic cardiomyopathy, subvalvular pulmonary stenosis, and other abnormalities. So we will focus on hypertrophic cardiomyopathy due to genetic mutations. So the variants of hypertrophic cardiomyopathy, the most common locations of hypertrophy, subaortic, septal, anterior wall. So we can see that asymmetrical hypertrophy by the presence of septum to posterior ratio more than 1.3 is responsible for around 70% of cases of hypertrophic cardiomyopathy. Basal septal hypertrophy in 15 to 20%. Concentric LVH is another variable of hypertrophic cardiomyopathy, which can be seen in around 8 to 10%. And the characteristic Japanese type, known as Magayushi type or apical hypertrophic cardiomyopathy, less than 2%, but it's present in the Japanese in around 25%. So the pathophysiology, which is responsible for the clinical manifestations of hypertrophic cardiomyopathy, is due to the presence of one or more of the following criteria: left ventricular outflow tract obstruction at rest or with provocation, diastolic dysfunction, myocardial ischemia, mitral regurgitation, and at the end stage, left ventricular systolic dysfunction when the ejection fraction dropped below 50%. So hypertrophic cardiomyopathy, one of the most common causes of sudden cardiac death in young patients. So we can see heart failure in up to 90% of patients. Chest pain is very common in 30% of patients. Syncope in around 15 to 25%, which could be due to ventricular arrhythmias, left ventricular outflow tract obstruction, or autonomic dysfunction. Presyncope in 20%. Different forms of arrhythmias, like atrial fibrillation, ventricular arrhythmias, in 30% of patients. Sudden death is common, and the annual mortality rate for hypertrophic cardiomyopathy is 1%. So heart failure could be due to one of these pathophysiological abnormalities, which at the end lead to high left atrial pressure. So patients presenting with dyspnea, orthopnea, PND, and the low cardiac output leading to fatigue and lightheadedness. These are caused by high LVOT B, left ventricular end-diastolic pressure, mitral regurgitation, systolic dysfunction, low stroke volume due to diastolic dysfunction, LVOT obstruction, and chronotropic incompetence as well. So this is a classic cut section from a hypertrophied ventricle showing the hypertrophied septum for a case of hypertrophic cardiomyopathy. So in adults, for diagnosis of hypertrophic cardiomyopathy, one or more LV segments, 15 millimeter or more. In relatives, one or more LV segments, 13 millimeter or more. The gradient at rest, which is present in patients who have classic dynamic outflow tract obstruction, when the gradient is more than 30 millimeter mercury. However, in this disease, we have many challenges in diagnosis, like LVH in athletic heart caused by training may give a picture simulating hypertrophic cardiomyopathy. LVH due to hypertension or aortic stenosis. Isolated LVH due to infiltrative disease like amyloidosis, for example. LV non-compaction and end-stage wall thinning in cases of hypertrophic cardiomyopathy. Electrocardiogram is considered a class 1 level of evidence P recommendation, and in ECG we can see LVH, STTOV changes, T-wave abnormalities, inverted T-waves. Extended the 48-hour Holter ambulatory ECG monitoring class 1 level of evidence P to identify the presence or absence of ventricular arrhythmias, paroxysmal atrial fibrillation, for example. And this is a classic example for patients who have giant negative T-wave inversion in precordial leads, a classic apical hypertrophic cardiomyopathy. Echocardiography is mandatory, one of the most important imaging modality, class 1 level of evidence P. And in echo, we will assess the LV wall thickness, associated abnormalities of mitral valve, which is present in more than 50% of cases of hypertrophic cardiomyopathy. We can see elongated leaflets, elongated chordae, anterior displacement of papillary muscle, mitral valve prolapse, characteristic systolic anterior motion, which lead to obstruction. Assessment of latent obstruction, if you don't have a gradient at rest, provocation can be done by Valsalva or another pharmacological drugs, which can identify patients who have a gradient with provocation more than 50 millimeter mercury, left atrial enlargement, assessment of diastolic function, and ejection fraction. If it is less than 50%, this is an end-stage hypertrophic cardiomyopathy. So 2D and Doppler echo at rest and Valsalva and standing when needed, we can see patients who have a maximum provoked gradient more than 50. So those patients should be treated as patients with LVOT obstruction. While if the patients have a maximum provoked gradient less than 50, in asymptomatic patients, those patients need a repeated echocardiography after 1 year. But if they have symptoms, exercise stress echo is recommended. And if you have a gradient with exercise stress echo more than 50, so those patients have a classic obstruction and should be treated as LVOT obstruction, while if the gradient less than 50, medical treatment and follow-up is recommended. So in echo, you can see asymmetrical septal hypertrophy, septum to posterior wall ratio more than 1.3, systolic anterior motion, resting gradient more than 30, gradient with provocation more than 50 millimeter mercury, small LV cavity, septal immobility, mitral valve prolapse, or any mitral valve abnormalities with mitral regurgitation. And this is the diastolic as well as systolic frame from parasternal long axis view. We can see how much the hypertrophied septum compared to the posterior wall, and the classic systolic anterior motion, which is correlated with the presence of LVOT gradient, as we know that we have different grades of systolic anterior motion. And this is examples, different examples. A classic picture shows the hypertrophied septum and diffuse hypertrophy septum posterior wall, and we can see ICD lead in the right side chambers as well. Parasternal short axis view at the level of papillary muscles, we can see the hypertrophy, diffuse hypertrophy. And interestingly, many years ago, Maron's classification for hypertrophy type 1 involving the anterior septum, type 2 anterior and posterior septum, type 3 anterior, posterior, and lateral wall as well, and type 4, which is the apical hypertrophic cardiomyopathy. Parasternal long axis view showing the hypertrophied septum compared to the posterior wall, and we can see the D image, we can see the apical hypertrophic cardiomyopathy, and E, apical hypertrophic cardiomyopathy without contrast, and the last picture showing the use of contrast, and we can see the opacification of the ventricle and apical hypertrophic cardiomyopathy. And this is the gradient at rest dagger shape characteristic for the hypertrophic cardiomyopathy, which should be differentiated from the envelope due to mitral regurgitation, and you have to avoid contamination of the sample when you're estimating the gradient to avoid the estimation of a gradient due to mitral regurgitation. This is a classic picture. You have to take it for a dagger shape for in cases of hypertrophic cardiomyopathy, and with Valsalva, you can see more gradient as we can see. What about CMR in patients with hypertrophic cardiomyopathy? Another important non-invasive imaging tool to measure the LV diameter, volumes, ejection fraction, assessment of hypertrophy in details, especially if you are suspecting apical hypertrophic cardiomyopathy. And in cases of difficult diagnosis, the gadolinium allows the assessment of myocardial fibrosis, but assessment of prognosis was not retained by the European recommendation. So CMR is not only for diagnostic purpose, but also for prognostic purpose, as we'll see later, when you identify late gadolinium enhancement and myocardial fibrosis or apical aneurysm, because this indicates a high risk patients for sudden death. So it needs an expert in CMR to diagnose accurately hypertrophic cardiomyopathy and consider class 1 recommendation according to the European guidelines. And this is a classic CMR for septal hypertrophic cardiomyopathy. We can see the hypertrophied septum compared to the posterior wall and the apical hypertrophic cardiomyopathy. Very nice pictures for illuminating the role of CMR in diagnosis of hypertrophic cardiomyopathy. Transesophageal echo is considered class 1 recommendation for perioperative T is recommended in patients undergoing myectomy to guide the surgical strategy and to assess the outcome after surgery. Stress test in patients with hypertrophic cardiomyopathy is class 2A recommendation to determine the functional capacity, response to therapy, risk stratification for sudden death if you have an exercise-induced hypotension, drop in systolic blood pressure 20 millimeter mercury or more with exercise. Biopsy, sometimes endomyocardial biopsy is recommended to rule out myocardial infiltrations, inflammation, storage disease. Nuclear imaging class 2A recommendation in patients consistent with amyloidosis or to identify myocardial ischemia. Cardiac CT should be considered a class 2A in patients who have inadequate echo images and contraindication to CMR. And finally, coronary angiography is class 1 level of evidence C for detection of concomitant coronary artery disease or detecting myocardial bridge, which is common in around 25% or more in patients with hypertrophic cardiomyopathy. Do we need the genetic testing in every patient? Family screening, the role of genetic testing in those patients is important because it can identify 50 to 60% of patients with hypertrophic cardiomyopathy phenotypes, as we have different genetic mutations responsible for the disease. It does not provide reliable risk stratification or identify high-risk positive patients for HCM. However, the role of screening is to identify the potential at-risk relatives for hypertrophic cardiomyopathy patients. If you detect HCM in patients, so family screening and first-degree relatives, genetic tests can identify the risk for developing hypertrophic cardiomyopathy. So if there is no mutation in this relative, no further test is needed. And if mutation identified in a relative, so this carries the risk for developing hypertrophic cardiomyopathy, and this patient should be followed up regularly. This is an interesting slide because it shows the imaging phenotypes as well as clinical phenotypes. The imaging phenotypes includes echocardiography, CMR finding, CT angiography. So if we look for LVH, for example, detected by echo, CMR, and CT, the risk for sudden death, heart failure, atrial fibrillation, stroke, and angina are correlated with LVH detected by these imaging modalities. And obstruction, LVOT obstruction, is correlated with heart failure risk, atrial fibrillation, stroke risk, and angina as well. And it may play a role in sudden cardiac death. Myocardial fibrosis, which is very important to be detected in patients with hypertrophic cardiomyopathy with CMR or CCT, and it indicates the risk for heart failure, atrial fibrillation as well. And also it could be responsible for sudden death because this will create a substrate for ventricular arrhythmias. Microvascular ischemia detected by nuclear imaging, CMR, echo, also carry the risk for sudden death, heart failure, atrial fibrillation, and angina as well. So we diagnose the patients with hypertrophic cardiomyopathy by echo, CMR. So how to manage patients who have hypertrophic cardiomyopathy? Medical treatment or septal reduction therapy, surgery or alcohol septal ablation, or we have other modalities like dual chamber pacemaker. What's most important in every patient diagnosed with hypertrophic cardiomyopathy before considering the treatment strategy is to do a risk stratification. This is very important. So if we talk about medical therapy, beta blockers are considered in the cornerstone for treatment. It relieves symptoms, and however, it has no impact on reduction of sudden death. It improves symptoms as well as exercise tolerance. So it's recommended as the first line of treatment. Verapamil is considered class 1 level of evidence B, titrated to the maximum tolerated dose, recommended in patients who are not tolerating beta blocker or have contraindications to beta blockers. Disopramide is considered a class 2A recommendation. It has a negative inotropic effect, so it decreases the obstruction. Titrated to maximum tolerated doses is recommended in addition to beta blocker in patients who have symptoms not controlled with beta blockers alone. What about septal reduction therapy, surgical myectomy, or alcohol septal ablation? Surgical septal myectomy is considered a class 1 level of evidence B, and it is the procedure of choice in patients with resting or provoked graded more than 50 millimeter mercury who are in heart failure despite maximum tolerated medical treatment. Mitral valve surgery is required in up to 20% of patients undergoing septal myectomy. Complications of surgery includes AV plaque, creation of VSD, aortic regurgitation. the mortality rate is 1 to 2%, and heart failure is reversible post-operative. And this slide showed the site of the incision line through the hypertrophied septum, and this will lead to a widening of the outflow tract. In addition, mitral valve surgery can be done in the same setting. Alcohol septal ablation is considered a class 2A recommendation level of evidence B. It is an alternative to surgery when surgery is contraindicated or patients who have comorbidities or advanced age, and patients who have obstruction despite maximum tolerated medical therapy. How it can be done? It can be done by selective injection of pure alcohol, 95%, 1 to 3 cc, in the major septal perforator branch supplying the hypertrophied septum, which is responsible for obstruction. It is similar to surgery in terms of gradient reduction and symptoms improvement. However, it has a complications in the form of complete heart block in up to 20% of patients, and creating a large myocardial infarction, which could be responsible for serious ventricular arrhythmias. And this is a classic example. After doing coronary angiography, you have to identify the culprit septal branch, the major septal perforator supplying the hypertrophied septum, which is responsible for the obstruction. This is the target septal perforator, which will be injected by alcohol during the procedure. And when you are considering septal reduction therapy, either septal ablation or septal myectomy, you have to consider the risk of complete heart block, the operator experience. Patient's shared decision-making is very important to discuss the outcome of each procedure, the risk of each procedure. So in elderly patients, patients with comorbidities, limited expected lifespan, sedentary lifestyle, relatively low gradient, the thickness of septum is not so severe, the ablation may be considered in favor for these patients. However, the impact on the risk of sudden death is not good compared with septal myectomy, which is the gold standard treatment for patients who have high gradient, expected life expectancy more, and the impact for symptoms and relieving obstruction and prevention of sudden death have been proved in long-term studies for the outcome of septal myectomy in patients with hypertrophic cardiomyopathy. Dual chamber pacemaker, which was considered a treatment strategy in 1994, a new modality for those patients. The idea is to induce a paradoxical septal motion. So this leads to widening of the left ventricular outflow tract gradient with a drop in the gradient by doing sequential AV pacing with an optimal AV interval. It's class 2B recommendation. And this will facilitate also the giving beta blockers as well, and maybe consider in selected patients with LVOT obstruction more than 50 millimeter mercury who have contraindications for septal ablations or septal myectomy. Patients with high risk of developing heart block following septal ablation or septal myectomy also can be considered as a candidates for this treatment strategy. Risk stratification is very important in every patient diagnosed with hypertrophic cardiomyopathy, because sudden death is a devastating event and the unpredictable complication of hypertrophic cardiomyopathy. And it may be the initial disease presentation. Annual mortality rate is 1%. The major primary risk factors: family history of sudden death, unexplained syncope, massive LVH more than 30 millimeter thickness, young age, non-sustained VT, exercise-induced hypotension. However, other secondary risk factors, the detection of LV apical aneurysm, obstruction more than 30 millimeter mercury, left atrial size, extensive fibrosis detected by late gadolinium enhancement on CMR. So this is a nice hypertrophic cardiomyopathy risk sudden cardiac death prediction model by the European Society of Cardiology to detect the probability of sudden death at 5 years. If you use this calculator, which is available on the website of EC, detecting the probability of sudden death at 5 years using different variables like age, maximum wall thickness, left atrial size, maximum gradient, family history of sudden death, non-sustained VT, and unexplained syncope. So the risk of sudden death at 5 years can be estimated, and accordingly, the recommendation for ICD or not can be given. So to prevent sudden death in hypertrophic cardiomyopathy, you have to avoid competitive sports, ICD if a history of cardiac arrest or sustained VT with symptoms, estimated risk using the risk score and re-evaluated at 1 to 2 years, or if there is a change in symptoms, no evidence of medical therapy or alcohol ablation in prevention of sudden death. This is very important. So again, this slide shows the flow chart for the indications for ICD. Secondary prevention is very important in patients who develop cardiac arrest due to VT or VF, spontaneous sustained VT causing syncope or hemodynamic compromise. If the patient's life expectancy is more than 1 year, so ICD is highly recommended. And if we use the estimation of the score estimated by the score according to the EC recommendation, this flow chart for ICD implantation can be recommended. If we have HCM risk sudden death score more than 6%, this indicates that the 5-year risk is more than 6% sudden death. This is considered a high-risk patients, so ICD should be considered. But if we have the 5-year risk for sudden death is low, in less than 4%, so ICD generally not indicated, and the intermediate risk more than 4, less than 6%, ICD may be considered. And this slide shows the Kaplan-Meier graphs for survival and survival free of sudden cardiac death. And we can see the advantages of surgical myectomy followed by ablation compared with medical therapy in prevention of sudden death, up to 10 years follow-up of these procedures. And if the patient develop heart failure with an ejection fraction less than 50%, atrial fibrillation is very deleterious in those patients because they lost the atrial kick. And once they develop atrial fibrillation, deterioration and heart failure occurs in addition to the risk of thromboembolic event and stroke. So rate or rhythm control and anticoagulation are mandatory. And if the ejection fraction is more than 50%, the beta blockers, verapamil or diltiazem and low-dose loop diuretics are recommended. But if the ejection fraction is less than 50%, beta blocker ACE inhibitor MRA, the same treatment for HFrEF patients should be given, and transplantation in eligible patients who have an EF less than 50% in NIA class 3 to 4, despite optimal medical therapy or intractable ventricular arrhythmias, and this is a class 2A recommendation. 1 month ago, the new recommendation by the American Heart Association, American College of Cardiology Guidelines 2020 for diagnosis and treatment of hypertrophic cardiomyopathy. Very interesting new guidelines. And I will summarize these guidelines maybe in 3 or 4 slides. So this is very important slide again for risk stratification for sudden death. If you have a patient with family history of sudden death from hypertrophic cardiomyopathy in 1 or more of the first degree relatives in patients less than 50 years of age, this is very important. Massive LVH, wall thickness again more than 3 centimeters in any segment within the chamber, assessed by echo or CMR. Unexplained syncope, 1 or more, involving acute transient loss of consciousness, especially if a recent history of syncope. And we have to rule out syncope due to vasovagal etiology, neurocardiogenic, or syncope not due to LVOT obstruction. Patients who have LV systolic dysfunction with an ejection fraction less than 50% by echo or CMR, patients who have LV apical aneurysm, discrete thin-walled dyskinetic or akinetic segment detected by echo or CMR. Extensive late gadolinium enhancement on CMR imaging, fibrosis. This is a very important criteria for high-risk patients, especially if it involves more than 15% of LV mass. And if you have patients who have non-sustained VT on extended 48-hour Holter monitoring, and also if these episodes of non-sustained VT is repetitive, longer, faster, more than 200 beats per minute, this is very important to identify patients who have a high risk for sudden death. So this is an interesting algorithm. Patients who have hypertrophic cardiomyopathy treat comorbidities according to guidelines. If the patients have an obstructive physiology, symptoms, yes, so we have to treat those patients with beta blockers, which is the cornerstone for treatment, and avoid vasodilator beta blockers. If the patient is still symptomatic or have contraindication for beta blocker, verapamil can be given, and disopyramide should be added if the patient still have symptoms. And if the patient is still symptomatic, septal reduction therapy, ablation or myectomy. And myectomy is considered if the patients have another indication for surgery, such as mitral valve disease or mitral valve apparatus abnormality. This is a highly indicated surgical candidate to do septal myectomy as well as mitral valve surgery at the same time. Again, ICD recommendations by the new guidelines. Patients who develop sudden death, VF, sustained VT, it's mandatory to implant an ICD. It's class 1A recommendation. If the patients did not develop this event and they have at least one of the following: family history of sudden death, massive LVH, unexplained syncope, apical aneurysm, ejection fraction less than 50%, so ICD is a reasonable option. It's considered a class 2A recommendation. If the patient has not any of these 5 criteria and he has non-sustained VT, so ICD is reasonable, class 2A recommendation, especially in young patients. And if not, but have an extensive late gadolinium enhancement, CMR, fibrosis, so ICD may be considered a class 2B recommendation. If there is no, so ICD is not recommended and is considered a class 3 recommendation. So this is very important. After doing risk stratification and after assessing the risk for sudden death, these are the indications for ICD, class 1, class 2A recommendation, class 2B recommendation, which should be considered high priority to prevent sudden death, which is a devastating event in patients with hypertrophic cardiomyopathy, especially in young patients. And recently, a new drug have been investigated in a study known as Explorer HCM trial. The mavacamten drug, it is an inhibitor for cardiac-specific myosin adenosine triphosphatase, was studied in around 250 patients who have NYHA function class 2 to 3 symptoms, and patients who have hypertrophic obstructive cardiomyopathy. The results of this drug compared to placebo, that patients who were given mavacamten achieved an improvement in peak oxygen consumption by at least 1.5 milli per kg per minute, a reduction in NYHA function class by 1 or more, And all secondary endpoints, including post-exercise LVOT gradient or biomarkers of cardiac wall stress, like NT-proBNP or high-sensitive troponin, decreased significantly with the use of this drug compared with placebo. So if you look for the post-exercise LVOT gradient, compared with placebo, starting from a gradient of 84 or 50 millimeter mercury, the gradient with mavacamten was significantly lower compared with placebo, 38 compared with 73. If you look for the resting gradient after randomizing those patients to mavacamten versus placebo up to 30 months, we can see a gradient of 50 decreased to 14 with mavacamten compared with 45 with placebo. Ejection fraction, there was no significant difference, and Valsalva gradient also decreased significantly with mavacamten compared with placebo. And if you look for the biomarkers decreased significantly with mavacamten, starting from 700s up to 163 picogram per milli reduction compared with patients who were given placebo, 64.5 picogram per milli. And the high sensitive troponin, the same, decreased significantly. So the conclusion of this study that treatment with the new drug mavacamten improved exercise capacity, relieved the LVOT obstruction, improved NIA function class, and the health status in patients with obstructive hypertrophic cardiomyopathy. And this is a new drug which is a disease specific for patients with hypertrophic obstructive cardiomyopathy. So at the end, the take-home message for this fascinating disease, that hypertrophic cardiomyopathy has different phenotypes, genetically, phenotypically, clinical presentation, diverse etiology. And interestingly, the patients with hypertrophic cardiomyopathy may be totally asymptomatic or may present as sudden cardiac death as the first presentation. So you have to consider it that it is a disease of wide range of presentations, from asymptomatic status to positive family history, the presence of murmur, abnormal ECG, echo, heart failure symptoms, symptoms of obstruction, or sudden cardiac death. Multimodality imaging is very important for diagnosis as well as for risk stratification. Echocardiography, CMR. Risk stratification is critical for every patient diagnosed with hypertrophic cardiomyopathy. And the ICD is strongly recommended in high-risk patients to prevent sudden cardiac death. In addition, we have pharmacological and non-pharmacological treatment. We have septal reduction therapy, septal myectomy and alcohol septal ablation. We have a cornerstone for drugs like beta blockers, like verapamil, like disopramide. And recently, we have a new molecule, which is mavacamten, which proved to decrease obstruction and improve symptoms in patients with hypertrophic obstructive cardiomyopathy. Thank you for your attention. And now we can answer any questions related to this presentation. Dr. Assam. Stop share.
دكتور مجدي، وهنقدر نعمل الاكسرسايز ايكوال ازاي؟ التريدميل ولا بالدوبيتامين؟
If the patient cannot exercise, so dobutamine, but you can do it exercise, treadmill. So both can be done.
Limited, symptom limited?
Yes.
Symptom limited?
Yes, the idea is to increase the heart rate, and this will as a provocation for the gradient. So not all patients can do the exercise well. So you can do the vitamin, you can do exercise according to the availability. And the rationale is to provoke a gradient which is not estimated at rest. But at the same time, sometimes very common sublingual nitrates, Valsalva, all these maneuvers can estimate gradients which is not present at rest in many patients with hypertrophic cardiomyopathy who have lower gradients in the form of 20, 15, and then with provocation, you can see more gradient with the increased heart rate and contractility and increased obstruction. طبعا new guidelines يعني it's very interesting الحقيقه. I recommend ان احنا كلنا نقرا الجايد لاينز دي لان هي فيها different algorithms starting from diagnosis up to management. Very interesting algorithms, especially risk stratification, different modalities of treatment, the indications of ICD. Because you know that hypertrophic cardiomyopathy is a disease it's variable, and you have to individualize your treatment strategy because, for example, hypertrophic cardiomyopathy in young patients is totally different in elderly patients. In elderly patients, it is a benign course. You can see hypertrophic cardiomyopathy discovered for the first time in a patient at the age of 70, and he is totally asymptomatic. While the course in young patients is malignant course. It's not a benign course, and sudden death may be the initial presentation in a young of 16 years age. He was totally asymptomatic, and sudden death may be the initial presentation. So it is a heterogeneous disease. It is variable from the genetically, phenotypes, clinical expression, and as well as the management strategy. Not all patients are treated the same.
Magdy, may I ask a question, please?
Yes.
First question is about old age.
ممكن نعلي صوتك، أنا مش سامع. مين؟
أنا محمد علي فايد يا فندم.
محمد علي فايد.
I want to ask a question. In old age, as you said now, in 70s, we found a senile hypertrophy of the septum. And sometimes these patients are dehydrated. We may find an LVOT gradient. How to deal with these patients? Should we repeat an echo after good dehydration? And this senile hypertrophy, how to ensure it is only senile hypertrophy of the septum or it is an hook? This is my first.
لا الجزء الأخراني مش سامعه كويس، الصوت بيقطع كده مش عارف.
The patients with old age have senile hypertrophy.
Commonly seen septal hypertrophy in patients who are elderly, yes. So
and sometimes they are dehydrated, and their LVOT may have an gradient.
Yeah, if you are expecting that these patients have an obstruction and have mitral valve SAM for example, and you are going to estimate the gradient with provocation and after proper hydration. So especially if the patient's receiving diuretics, and you know that diuretics exaggerate obstruction. Patients who have obstruction should be very cautiously when you give him diuretics. So in those patients, patients who have hypertension, the diagnostic criteria for hypertrophic cardiomyopathy is different from patients who are not hypertensive. Because in this situation, the ratio should be 1.5 or more. Septum to posterior wall should be ratio 1.5 or more, not 1.3 or more like patients who are not hypertensive. And if you are suspecting obstruction, CMR will be of a good value to assess if this patient has a significant obstruction or not. Of course, the management in elderly patients are different from young patients because those patients have comorbidities, may have concomitant coronary artery disease as well. So the treatment approach is not the same like young patients who have a very high gradient family history of syncope. So those patients, if they have a significant obstruction responsible for symptoms like angina, like syncope, for example, So septal ablation will be considered, not septal myectomy at this age. But the majority of those patients can be treated medically well, just beta blockers only.
And about patient with HCM, how about diuretics in patient with heart failure symptoms? How can we deal with this situation?
The minimum doses which relieve symptoms of congestion without exacerbation of the gradient. A flexible diuretic therapy to relieve symptoms and signs of congestion without exacerbation of the gradient. But if the patients have a low ejection fraction below 50 and have an clear evidence of heart failure, so those patients will be treated the same as HFrEF patients.
Thank you, sir.
Any questions? طبعا احنا في الاسم عندنا يعني كان لينا اكسبيرينس في الهايبرتروفيك كارديوميوباثي. انا مثلا 1994 رساله الدكتوراه بتاعتي كانت على الديوال تشامبر بيسنج في الهايبرتروفيك كارديوميوباثي. And we published these data في الامريكان كوليدج وفي الاي سي سي، وكانت لسه يعني a new treatment option for patients with hypertrophic obstructive cardiomyopathy. And I discussed the rationale of this new therapy at that time to do a paradoxical septal motion, widening of outflow tract. And we documented some improvement in patients. Not all patients, up to 30% of patients responded, especially patients who cannot be subjected to surgery at that time, because you know that the surgery is a very complicated surgery. It needs an expert because the complications are high: VSD, aortic regurg, complete heart block, heart failure. All these are major complications for hypertrophic cardiomyopathy. And the recommendations by different guidelines for dual chamber pacemaking was class 2B recommendation, should be considered in elderly who are not good candidates for septal ablation or for septal myectomy. Then we did another study. كانت رسالة دكتوراه لأحد الدكاترة عندنا في الاسم، أفتكر كان دكتور محسن خيري مستشفى الطلبة، كان مشرف عليها أستاذ الدكتور عادل زكي وأنا، وكانت على septal ablation في الهايبرتروفيك كارديوميوباثي in a good number of patients. The procedure also needs an experience, needs selection of patients. The most important factor, selection of patients. To select patients who have septal perforator target to be ablated, which is responsible for the obstruction because it is supplying the hypertrophied septum. So you have to inject a contrast, you have to visualize the septum well, you have to identify the target vessel well, and inject alcohol very cautiously, 1 to 3 cc, estimate the gradient, doing echocardiography bedside during the procedure, and the complications also are high. Complete heart block can occur in around 30% of patients. You can induce a big infarction, and a lot of complications have been described in many trials. You can induce a big infarction, and mortality sometimes is a complication, especially if the operator is not well expert in this procedure. So the standard of treatment, if the patient is not at high risk for sudden death, is medical treatment. I have many patients who are doing well on medical treatment, just beta blockers, and avoid all factors which lead to exacerbation of the gradient: competition, spouse, exercise, accelerating heart rate, etc., dehydration, diuretics, and they are doing well with the medical treatment. But before deciding the proper treatment strategy, you have to subject your patients to risk stratification to rule out high-risk patients for sudden death, because at this stage you will send him to implant ICD, and then you will manage him medically or surgically according to the criteria that you have. إذا ما كانش في أسئلة يعني نشكركم بقى، ولا في حد عايز يسأل قبل ما نشكركم؟ مفيش.
هو في بس يا دكتور مجدي سؤال في الشات. في سؤال في الشات بيسأل عن management of hypertrophic cardiomyopathy in patients presenting with cardiogenic shock.
ده يعني cardiogenic shock if it is due to rapid atrial fibrillation, for example, cardioversion to revert him to sinus, because rapid atrial fibrillation, one of the complications that can precipitate this, and ventricular arrhythmia as well. So cardioversion immediately for these patients should be done. You have to rule out acute myocardial infarction. There have been many reported cases for myocardial infarction for patients who have hypertrophic cardiomyopathy. They have myocardial bridge. They have compression of the coronary arteries during systole by hypertrophied septum. They have myocardial oxygen supply demand imbalance due to the hypertrophied septum, so they can develop myocardial infarction type 2. So you have to rule out the precipitating cause for cardiogenic shock, which can be treated at this stage. Arrhythmias, myocardial infarction. You know that with the use of inotropes in such cases, this can increase the gradient, but you have to use vasopressors, device therapy to support your patients and treat the patients of cardiogenic shock well until you can decide what is the proper treatment strategy for these patients. But it's very important is to look what is the cause of cardiogenic shock, reversible factors which should be treated first, support your patients pharmacologically and hemodynamically by mechanical or pharmacological approach, and then look for further after management of cardiogenic shock for a proper treatment strategy according to the different recommendations that we discussed before.
وفي سؤال برضو تاني في الشات يا دكتور مجدي بيسأل in a patient who had septal reduction therapy for massive LVH only, should we still implant ICD post surgery?
If the patient is a high risk for sudden death according to the risk stratification, of course, yes, because septal ablation and medical treatment only have no impact on sudden death. So if you did alcohol septal ablation and the gradient reduced from 80 to 20, this is a successful septal reduction therapy by septal ablation. But if this patient is a high risk for sudden death, family history, young age, syncope, etc., the criteria that we discussed before, so ICD should be considered in spite of the reduction in the gradient, because he is a high risk, because septal ablation did not prevent sudden death. And I think the interesting slide that I had presented comparing the survival overall and survival due to reduction of sudden death was very clear for superiority of myectomy compared with septal ablation and medical treatment. الشات في حاجة تاني ولا خلاص؟ ده محمود ولا مش ثابت اللي بيتكلم؟
أنا محمد ثابت.
أيوة محمد.
في سؤال تاني برضو مشابه للسؤال اللي قبل كده بيسأل if we have a patient who had myectomy, should we insert ICD if the patient has no other risk factors for sudden cardiac death?
No. If this patient has not the criteria for sudden death, no. I will maintain him only for beta blocker after septal myectomy. شكرا جزيلا.
شكرا لحضرتك دكتور مجدي.
ألف شكرا يا دكتور مجدي. شكرا يا دكتور مجدي، ربنا يبارك فيك
شكرا
وتقبل
شكرا يا
منك.
دكتور عصام بيه.
شكرا
شكرا
حبيبي.
لحضرتك.
شكرا حبيبي. اتفضل.